Hi, good night, everybody. Welcome back to one program in our long series called Genie in a Bottle. The time is 8 o'clock with 2 minutes in Mexico City time, 9 o'clock with 2 minutes in New York City time. The weather in Mexico City tonight is rainy. This Tuesday, June 29th of 2021, it's raining and it's 17 degrees Celsius. On the contrary, in New York City is 32 degrees and a very clear night. We welcome you to this very, very special program with Dr. Michael Glick. He is normally the co-host, but this time, and because of the nature of the program, we're going to have a very, very interesting and important lecture about the Vision 2030, which is a guideline for dentistry worldwide in the century that in the decade that just began. For those of you, we have three channels tonight. We have ID Academia courses. It's going to be in original audio in English. We have ID Academia courses in YouTube, which is also going to be in the original audio in English. And we also have a Facebook ID Academia, the regular where you normally see the programs. It's going to be translated by our friend Lilia Castañeda, which I thank her very much in advance. She's a great translator. She has been together with the Mexican Dental Association for the past 10 years doing translations, both when we used to have all the congresses where we gather all together, and now she's going to be with us in these virtual lectures. Para todos aquellos que no saben en qué canal vernos, les platico que en ID Academia Courses, tanto en Facebook como en YouTube Live, van a poder ver el audio original en inglés. Y para los que entraron en el Facebook de ID Academia, el tradicional, ahí es donde contaremos con la traducción instantánea de Lilia Castañeda, que ya nos acompaña en este tipo de eventos dentales. Excelente traductora inglés-español, español-inglés. Now I'll go back to English because otherwise the production will go crazy. We have to do this channel only English, so the other one can be only Spanish. And I cannot go and introduce our guest tonight before stating that I completely disagree with the comments made by the Associate Minister of Health in charge of the pandemic and of other health situations in Mexico. His name is Dr. Hugo López-Gatell. Since he has been in office for almost 3 years, there's a huge lack of medicine for children with cancer, all kinds of cancers. And it's amazing and incredible how myself and the people who work towards this program, we do it completely pro bono. We don't get any reimbursement whatsoever, but we do have advertising because that helps us pay for this production. So with nothing more, please, we'll go to a short video and then we come back with tonight's guest, Dr. Michael Glick.
¿Quieres que tus pacientes muestren su mejor sonrisa? En Ideas Dentales te ayudamos a lograrlo. Porque las ideas son mejores cuando las trabajas en equipo, te ofrecemos los mejores materiales para tus impresiones, resinas, grabadores, diagnóstico y prevención, así como insumos y equipos CAD/CAM. Ideas Dentales, tu aliado para crear las mejores sonrisas.
Hi, Michael. How are you?
Good. How are you doing, Jaime? Long time not see.
Yeah, we haven't seen each other well in person on the phone and through these programs. We see a lot of you, and we thank you
Yeah.
for accepting. I know you're in a new phase in your life, professional phase, and I'm really thankful that you found the time to spend this time with us, especially with all the dentists in Mexico and Latin America, and to understand the work that has been done by you since 10 years ago, first with Vision 2020, then with Vision 2030. And I think that we want everybody to listen in order to understand all the changes that will be needed in the close future in order to practice dentistry with excellency and with good results for our patients, no matter where in the planet Earth we practice our beloved profession.
Well, as you know, we can only predict so far and so much. I would love to be able to redo my prediction every week or every month if I could, but we have to start somewhere. So hopefully, with this little presentation I do today, it's a starting point. And as you're going to see, actually, I'm going to come up with more questions than with answers. And I think that's a good way to start this type of thing. Where do we need to go? And unless we can ask the right questions, we can never get the right answers, unfortunately.
Great. So we're going to show your a very short CV of yours. People know you. You're a dentist, a professor, and a researcher. You serve as editor of the Journal of the American Dental Association, JADA, until last year. You serve as president of the American Board of Oral Medicine. You are a recovering dean, as you call yourself, Buffalo School of Dental Medicine till August of 2015, 6 years ago. And you are an editor of 10 textbooks of dental management and oral medicine and has published over 300 articles on health related topics. And by the end of your presentation, we'll add probably a new line to your brief resume.
Sounds good to me.
Okay.
Anytime you're
Okay.
ready.
So let's go to a very, very, very short video, and we'll be back straight with your presentation.
Thank you, Jaime. Okay, good evening, everyone, and welcome to the Genie in the Bottle. I'm in New York City, and I know some of you are in Mexico, others are all over the world. We have a tremendous amount of people watching these programs from all over the world, so I welcome all of you, and I hope I'm going to keep you interested for another 45 to 50 minutes. First, let me just say that I'm a little bit mischievous with my lecture title here. I called it Integrative Oral Health. And what I mean by that is that when you hear those words, we can interpret it very different ways. For instance, if I ask all of you what oral health is, most of you are healthcare professionals, you'll probably give me a lot of different definitions. And that's okay, but it's not okay if we want to promote our health and all of us going to have the same message. So, what I'm going to try to do today is I'm going to try to forward to you or present to you a lot of different questions that I have. And one of them is the lack of standardization that makes the interpretation of our health research it's very, very difficult. And it's also very detrimental not only to improving health and well-being, but also for advocacy and for what we now call evidence-informed health policies, because if we cannot agree on what we are trying to promote, then obviously we don't have one voice, and we need that. So one of my goals today, and probably one of the most important goals I have today with this presentation, is to highlight some of the pertinent, important questions that we need to ask ourselves and find answer to in order to achieve an integrated approach to global oral health. Next slide, please. I don't have any disclosure, I don't have any financial relationship with any commercial interest, and this presentation is not going to contain any reference to any drugs or any product. Next slide, please. So what is needed to eliminate preventable oral diseases and achieve optimal oral health for all by 2030? So what do I mean by that? The vast majority of oral diseases are preventable. It's caries, it's periodontal disease. And when I talk about optimal oral health, I mean that we cannot all achieve the same type of health. There's no question about it. It's genetics, there are many other reasons for it, but we are going to try to achieve the best oral health that each one of us can achieve. So the first thing we need to do is ask the right questions. Next. We need to find realistic answers. Next. We need to identify barriers. Next. We need to try to implement, as far as we can, solutions when we have identified these barriers. And then we need to track the progress to these solutions. Next. We need to identify what works the best, maybe not only in our country, but in other countries, and see if they can apply to other places in the world. Next. We then need to track progress again. Next. And then we need to make things better. One thing that I'm very, very focused on, I have been for many, many years, is not that we think about things all the time, but how we think about things differently. We shouldn't be satisfied with what we have. We need to keep asking questions and figure out how we can improve things. So although I'm used the words best buys, I'm a little bit not happy with that, but WHO is using that. So best buys are the best ways of doing things. Well, they are maybe the best way to do things today, but we cannot be complacent and say, well, they're the best buys, we don't need to do anything else. My big concern is that when we try to have accomplish what we want to accomplish, we stop. And I hope we're not going to get to that position. I hope that even that we can accomplish what we want to accomplish, we're going to keep and innovate. And that's why I put the word innovate here. So what is lacking? Why can't we make as much progress? And I'm going to show you that we haven't made a lot of progress. So what's the problem? Next slide, please. Well, my big issue is actually data. Next slide, please. When I talk about data is that we have numbers, and you're going to hear a lot of numbers today. I'm going to talk about how many people in the world have oral diseases, how many get new oral diseases every year, and so forth. But the numbers don't lie, but do we have the right numbers? Next question, please. Next question, next slide. So one thing is, are the data standardized? For instance, when I say periodontal disease, do everyone agree that when I say periodontal disease, we talk about the same thing? We talk about the same probing death, we talk about the same attachment loss, we talk about the same bleeding index. We need to standardize things. Another example is oral cancer. When I say oral cancer, do I mean squamous cell carcinoma? Do I mean HPV type of oral cancer? Is it oropharyngeal cancer? And so on and so forth. Next slide, please. So how far down do we go? For instance, let's go back to periodontal disease. Is it enough just to say you're periodontal disease? Or should you say, well, you're periodontal disease with a certain pocket depth or with a certain bleeding index? Or should we go even further? Maybe we should go and say, well, there's certain proteins that need to be present, there's certain bacteria need to be present. So we don't know the granularity yet. We don't know how far down we need to dig in order for us all to speak the same language. Next slide. And how all-inclusive and recent are the data? Much of the data that we have today are years old, and they're not inclusive in the sense that it could have been taken from a very small cohort of the population, and then someone then extrapolated and say, well, that is what we find in the entire population. That cannot be done, and unfortunately that's what we've done a lot with oral health data that we have today from all over the world. Next. How are the data analyzed? Next. meaning how it's broken down, and how is our data synthesized. When we break down the building blocks of the data, how do we build them back up again in order to get something that is more understandable? Next slide, please. And who will have access to the data? Should everyone? Should politicians? Should researchers? Should patients have access to this data? Next slide, please. And how useful is to collect the data for any particular purpose? Unless we ask ourselves all of these questions, in that case, next slide, please, we cannot answer the question, what is the cost to collect the data we need? Because if we don't have a particular purpose and we don't know how to use it, no one is going to pay for us to collect all this data, obviously. Next slide, please. So the largest study ever done is something called the Global Burden of Disease. It's an article that was published initially in 2018 in Lancet, and they looked at 354 causes in 195 countries and territories for almost 20 years between 1990 and 2017. I talk about not only oral diseases, but a lot of different diseases. Next slide, please. And what they calculated here was, if we have so many people with so many diseases and so many new of these diseases occurring every year, what do we know about this? And how can we use this information to improve health? So in these studies, they used updated and extensive body of literature studies, survey data, surveillance data, inpatient admission record, outpatient visit record, health assurance claim, and so on and so forth. And they had over 68,000 different data sources. This is very comprehensive, no question about it. Next slide, please. Now, taking all of this data together, all of the information got from all of the different diseases, what did they find? Globally, for females, the cause with the greatest age standardized prevalence, meaning if I look today in the world, what disease do most female have? Oral disorders. For male, oral disorders. Next. And that hadn't changed between 1990 and 2017. So as I mentioned before, most of these are disorders, and they looked at specifically caries, impermanent teeth, deciduous teeth, periodontal disease, oral cancer, and what they call others. Most of these disorders are obviously preventable, yet they hadn't changed in the past 20 years. Next slide, please. If you're going to look at these data, you're going to find numbers. So if I look at oral diseases as an example, it's estimated that we have almost 3.5 billion people with oral disorders today. Next slide, please. And not only that, but if you look at the incidence cases, meaning how many new cases are going to happen in the next year, the incidence cases over 1 year, well, you're going to find that oral disorders is ranked number 3. Now, you have to notice something interesting here, and this is something that I never heard anyone discuss before. If you look at diseases, for instance, upper respiratory infections, you will see that there are 17 billion cases. Now, there are only 7.9 billion people, so how can there be 17 billion new cases in a year? What they must have done is they calculate someone who has an upper respiratory infection, they then become healthy, and then they have another respiratory infection and go back and forth. So those 17.1 billion is not unique individuals. Those are individuals with that type of infection over a certain time period. So if I look at oral disorders, there are 3.5 billion people, but there are 3.6 billion new cases every year. So here again, there are individuals that we count more than once. So therefore, that's what I'm saying. The numbers are right, but how do we actually analyze these numbers? It's a different story. The only thing I can tell you is I don't know exactly what the numbers are, but the magnitude is enormous. Next slide, please. In this article that came out here, there are around 31 pages of tables. Next slide, please. And what I did here was that I took out the slides that had to do oral disorders. So here you have caries of deciduous teeth, caries of permanent teeth, periodontal disease, people without any teeth and dentulous, and severe tooth loss, and other oral disorders. What's interesting in this slide, next slide please, is if you take the first and the last column, and I'll put those together here. What they're looking at here is that what is the increase and decrease of those type of disorders over time between 2007 and 2017. And as you can see here, the increase and decrease are minimal. For oral disorders overall, it's 1.3%, caries around -2%, caries of permanent teeth at -4%, periodontal disease increased by around 3%, indenturism and severe tooth loss decreased by around 4%, other oral disorders around 0.2%. This, I don't think, is a very good mark for us in dentistry, that for the past 10 years, or even longer, actually 20 years from 1990, we haven't been able to solve this problem. Instead, more and more people are getting these oral disorders. Next slide, please. Now, there are updates on this, by the way, and you can go into this website here, thelancet.com/GBD, Global Burden of Disease, GBD, and you can look at updates. This is an update that came out in 2019. Next slide, please. In 2019, they looked at, instead of what we had before, they now looked at 23.1 million, what we call year lost because of disability. Even here, oral diseases ranked first when it came to prevalence, again 3.5 billion, and third when it came to incidence. Now it's up to around 4.4 billion, meaning even more people are actually developing oral diseases every year than they did previously. And this was published on October 17th, 2020. So with these big numbers, what I want to show you is that we have a tremendous problems in our hands, and it's something we cannot drill ourselves off. I did a quick little calculation here. Next slide, please. And what I did was I said, okay, if every dentist in the world, which is around 1 million dentists, they work 8 hours a day for 220 days a year, and they dedicate 1 hour per patient, it would take around 2 years for every dentist in the world to actually treat 3.5 billion patients. But don't forget, you have another 3.6 to 4.6 billion new patients every year as well. So as you can see, we cannot treat ourselves out of this problem. We have to be able to prevent this problem, because treating it we are not going to be able to do it ourselves. No question about it. Next slide, please. So if we cannot do it, are there any things we can do with our workforce? And this is a big issue that's going to happen in the next decade or so. This is a very interesting study that just came out in 2021. And they looked at all the studies been done on workforce in oral health. And what they found was that all the models we used to discuss what type of workforce is needed, they were very weak. And they were limited in data sources or the availability of necessary data. Next slide, please. And not only that, they also had something called, they were limited to horizontal integration, meaning horizontal integration is that when you look at a workforce, that only dentists can do it. Well, that's going horizontally. If it went vertically, I could say, well, maybe the workforce should include dentists, maybe nurses, maybe physicians. Now go vertically. Maybe people who are not dentists could get involved. So if we plan for future oral healthcare workforce, we have to first of all get good data. And then we have to get out of this whole thought process that only dentists can do what we call dentistry. There's a lot of prevention we can do that you don't need to be a dentist. We did a, for instance, study in New York City where we had pediatricians, meaning physicians that take care of children, do varnish on children. Why not? You don't need to be a dentist to do something like this, and I can go on and on. So when we look at workforce in the future, let's not only look at what dentists can do and how many dentists we have. There's a lot of other people that can get involved in this, but we need the data, and we don't have the data. Next slide, please. So how do we get the data? Well, one way we can do it, we can do research. This is also a very interesting article that just came out in 2021. And they looked at clinical trials that have been conducted all over the world in the past 10 years, between 2010 and 2019. And they found close to 325,000 randomized clinical trials. And what they found was that only 5% of those trials were set in South Asia, and only 2% in Sub-Saharan African countries. So if I do a study in the United States, can I apply what I found in the United States to Sub-Saharan Africa or to Asia? I doubt it. I don't think we can do that. I think what we need to do, we need to start to broaden the reach of where we do these studies and go to the areas where that are most needed. I cannot sit in the United States and tell any of someone in Ethiopia how to treat oral diseases in Ethiopia. I have to do the trial, I have to do the study in Ethiopia in order to do that. The same thing in Mexico. You have to do your studies in Mexico in order to figure out what the problem is in Mexico and how you, with your circumstances, can figure out how to get a handle on the burden of oral disease in your own communities. Next slide, please. Next slide. There we go. So another big initiative that's going on right now is something called, next slide, is something called the Lancet Commission on Oral Diseases. In 2019, the Lancet published what we call a groundbreaking oral health series. They published a couple of articles in Lancet, and the Lancet is a medical journal. But they thought it was important enough to actually start what we call a Commission of Oral Health, meaning a committee of individuals from all over the world that were researchers, that were epidemiologists, that were physicians, that were dentists, and so on and so forth. They come together and try to figure out how do we deal with this global burden of oral diseases. And I would really encourage you to go and take a look at these articles. They were published in July of 2019. It was 4 or 5 articles that were published. You should read them. They are very thought-provoking and nothing else. Next slide, please. So here's the Lancet Commission, and it's again, there are a lot of commissions of different conditions, but specifically the Lancet Commission on Oral Health. This is the one is run out of University College of London, and is run by Richard Watt and his colleagues, and then they have done a fantastic job. And they keep publishing. They had another publication just came out a couple of days ago, which I'm going to show you in a couple of slides here. So keep looking for the Lancet Commission, look what's published in the Lancet, and look for their thought process and how they think that they're going to be able to help to solve the global burden of oral diseases. Next slide, please. What about WHO? Well, this is an article that just came out, June 23rd, and one of the authors here is again Richard Watt. Achieving sustained and affordable access to essential oral healthcare services and prevention for almost 3.5 billion people affected by untreated oral diseases require impactful policy solution and radical system reform. Next slide, please. So in the little corner right here, I highlighted for you. These are the key recommendations that comes out of WHO, the World Health Organization right now. Inclusion and community engagement, place equity and social justice at the core, and tackle sugar as a major common risk factor. Next slide, please. Without going into too much details. Embrace major system reforms. I'm going to talk more about that. The whole healthcare system, how you're going to be reimbursed in the future, is changing dramatically in the United States and all over the world right now. Better data for decision making. As I mentioned before, we don't have the good data when it comes to oral health, and we need to be able to collect the data, and we need to analyze it, we need to synthesize this, and we need to be able to discuss this data in order to inform us how to move forward. And then we need to close the financial gaps. In the United States, as an example, 41 million people don't have dental insurance. Not only that, after you turn 65 and you get something called Medicare, meaning it's a national insurance more or less for health, there's nothing in oral health in that at all. So after 65, if you cannot pay for oral health in this country, in the United States, you don't have oral health care at all. Next slide, please. So what did we do in FDI? For the past 2 years, we actually been trying to figure out, is there a way of moving forward? Could we actually create some type of roadmap or map at least in order to see where we're going to go in the next 10 years? What are the challenges? What are the opportunities? So we are a profession right now that we need to embrace, we need to accept that change is here. And we need to start to advocate for better integration of our health within overall health. Next slide, please. And I'm going to get into more into details what that means. So the Vision 2030 came out in January 18th of this year. It identifies a number of key present and emerging challenges for our profession, now professional autonomy, meaning how we can be an autonomous profession, And it sets out how these can become opportunities to improve our health, reduce our health inequalities, and contribute to reducing the global burden of oral disease. Now, what we put into this document, and you can download this document, by the way, from the FDI website, what we put in here are certain strategies and specific strategies, but we don't claim that they're going to work everywhere in the world. Next slide, please. But what we do in this document is the same thing I'm doing in this presentation here. Next slide, please. Is that we are asking the questions that need to be asked. So in Vision 2030, we identify a number of key present and emerging challenges. We talk about the different opportunities, and we need to focus on how to deal with them in order to move forward. So the report outlines that how we integrate our profession within global policies and to drive healthcare delivery forward should include what in the United Nations called the Sustainable Development Goals, and something also now that has been approved by the UN, something called universal health coverage. We're going to talk about in the next couple of slides. Next slide, please. Next slide, please. All right, next slide, there we go. So the bottom line here is that we have a high burden of our disease. We have inadequate population level prevention and effective care for those in need, and that's all over the world. We need to figure out with a new emerging type of health delivery system, how can we directly and indirectly be involved, and how will it affect our profession? And how do we present emerging societal changes that require our health workforce to be resilient and can adapt? And we can just look at something like migration or aging as two examples. Aging is a huge problem in the sense that people who are getting older, obviously, many of them will develop periodontal disease, caries, maybe lose all their teeth and so on and so forth, but they're going to live much longer, which means we need to change the way we treat patients because the workforce is going to be different. We need to prevent this. And I'm going to talk about one specific issue that's very, very close to my heart in a couple of slides here, where I think there might be part of a solution. Next slide, please. So something very interesting happened actually on January 18th and 19th in Geneva. There was a resolution for WHO to adopt oral health as one of the priorities moving forward. And this was a resolution actually that was put forth by Sri Lanka and then supported later by 44 different nations. Keep going. Next slide. And in this resolution, specifically talked about the following. They acknowledge that there are many risk factors that oral diseases share with non-communicable diseases. And I'm going to show you that in a slide later on. So not only do we have a connection between them, that one may cause or affect one another, the risk factors for these diseases are the same. And also in this resolution, which was very important, they talked about the necessity to integrate strategies on our health, promotion, prevention, and treatment into all type of disease policies. Next slide, please. And the concern also that our health services are among the most affected essential health services. Now, this was important here in the United States because it was the first time actually that WHO highlighted that our health services are essential, meaning they're necessary for well-being and health. And this is very, very important. Next slide, please, because that's going to influence how policies are going to be made in the future. So what this resolution wanted to do was they want to adopt a global strategy by 2022. And by 2023, they want to have an action plan. They want to track the progress with clear measurable targets to be achieved in the next 10 years by 2030, where no one is left behind, meaning everyone in the world should be included somehow, and contain the use of provision that modern digital technology provides in the field of telemedicine and teledentistry. This is the first time ever again that to talk about telemedicine and teledentistry working together in order to figure out how to solve this problem with all these people with oral diseases. And then they also talk about developing these best buys. Next slide, please. So this went forth to the 74th World Health Assembly. Next slide, please. And on May 26, the resolution was actually adopted by the World Health Assembly. So today, it's in place. So now we're going to see what's going to happen by 2022. Are we going to have these policies in place? Are we going to see the action plan by 2023? And it's very exciting right now, because if the World Health Organization have put this on their agenda and they have decided and they have promised us that they're going to come up with strategies, we have to figure out how these strategies are going to affect our profession and how we provide dentistry. Next slide, please. So where do we go from here? Next slide, please. Well, we know that the burden of our disease is one of the highest of all non-communicable diseases. Next slide, please. So why is that? Because people are not aware of the problem? Well, now we are more aware of it than ever before. Maybe it's the way we practice. Maybe we treat the disease rather than prevent the disease. Do we have an adequate number of oral healthcare professionals? Do we need more dentists? Do we need something else than dentists? What about availability and access? And I differentiate between those two. Availability meaning, do we have enough? And access meaning, can a patient actually go and see a dentist? How does the dentist or whoever provide the services, how are they going to be reimbursed? Do we reimburse them correctly in a way? And do we have policies that are adequate enough in order to integrate our health for everyone in the world that needs it? Next slide, please. And my biggest question is, are we sitting at the table? Next slide, please. Or are we just talking to each other without talking to the people that make decisions? One of my biggest challenges for the future is to be able to get dentistry to sit at the table with other healthcare professionals. If you don't sit at the table, you're not part of the solution, you're part of the problem. And we need to be able to train our healthcare professionals, students, residents, and present oral healthcare professional, to be able to advocate for oral health in order to get it into the policies, in order to sit around the table. But for that, we need data, and good data. Next slide, please. Next slide. Like 3-4 slide. So we have data. With data, we get information. With that, we get knowledge, and then we can have clinical judgment. But if we don't have good data, we don't have good information, we don't have good knowledge, and we cannot make good clinical decisions. Next slide, please. One of the biggest problems today, and it's something also is recognized by WHO, is not only do we have an epidemic out there, we also have something called an infodemic, meaning there is a lot of information out there that is not correct. Next slide, please. We can actually divide this information into 3 different big categories. There's misinformation, information that is false, but not created with the intention of causing harm. Disinformation, information that is false and deliberately created to harm a person. And then we have malinformation, information that is based on reality used to inflict harm on a person, organization, or a country. We have seen all of these during the COVID epidemic. And I think Jaime actually talked about it a little bit, actually, when he spoke about what's happening in Mexico right now when it comes to COVID. Is this misinformation? Is it disinformation? Or is it even malinformation? We need to be able to distinguish between them in order to figure out what the right information is. Next slide, please. So knowledge and understanding of basic statistical, clinical, relevant concepts are 2 of the essential elements of effective assessing credibility, clinical relevance of study results and conclusions. So now come back to data again. In order for us to use data, we have to understand when the data is published what it really means. Next slide, please. And unless we do that, for all practical purposes, we might be called scientifically illiterate. So when you read an article and the researchers in the article come up with certain conclusion, you have to be able to say, is this good? Is this bad? Is it ugly? Is it right? Is this good data? Can I use this data for information that I need, next slide please, in order to make decisions? So in order now to have the data, we need to understand the data. We need to take that data, make it into knowledge. We need to figure out if this data is good enough to use. So with that data, do we have the evidence? What is credible? What is sustainable? Meaning the evidence that we have, how long is that valid? And is it realistic to do what we want? Next 3-4 slide, please. You can go one by one very quickly. So what we need to do there, thank you. What we need to do there, we need to initiate program. We want to monitor the delivery of the program for the evidence-informed policies, evaluate and assess the impact, encourage innovation, and improve and scale the program. Very similar to what I said in the beginning of this presentation, how we need to be able to take data, initiate program, get them into policies, figure out what works, track the progress, figure out what works, and then keep innovating. Next slide, please. So one thing that we need to do, and we need to do much better, is to inform policymaker. Conclusion of this study that was done and published in 2018. Making researchers aware of the most effective manner in which to package their result, provide training to policymakers, and ensure that policymakers have technical access to appropriate databases to search for health policy, and need for researchers and policymakers to communicate. We're doing a terrible job when it comes to taking our data, our information, the research we have, and translate it to people who are not used to this type of data, who is not used to our type of language. And that goes back to my first slide when I said, in order to move forward, we need to speak the same language. When I say oral health to an oral health professional, it might mean something very different than oral health to a policymaker or to a physician. So researchers need to get the data, we need to understand the data, we need to train policymakers to assure them that they actually have the right and appropriate information. And then we need to do communication much, much better than we ever had before. Keep going. Next slide, please. Now, this was a study that came out in JAMA not long ago, also here in 2021. And they looked at something called high value care. What they're talking about here is that, the pandemic has shown us that it's not the treatment itself that is what we should get rewarded for. What we should get rewarded for is something called value-based care, meaning it's the patient's value, how they value the care they got, meaning did they get better, did they get sick, did they get cured? Those are the things that we're going to get paid for in the future. Next slide, please. Now, the reason I'm saying this is because if you look at, if you look at this, can we now say, for instance, that oral health gives value to health? Unless you have good oral health, do you really have good overall health? And the answer is probably not. So in 2019, the UN, they approved something called the universal health coverage. The universal health coverage is actually very simple. Next slide, please. It is, and this is a slide that I took from a picture inside the FDI's optimal oral health in 2030 document that I showed you. This was developed by one of the authors, Professor Manu Mathur, who is at Liverpool right now, and he came up with this idea of looking at these 5 E's. Entrench oral health as a political priority, execute appropriate legal and regulatory frameworks, effect long-term person-centered quality oral health service, establish meaningful multi-sectorial partnerships, and I'm going to talk more about that, encourage great investment in primary oral health care, ensure that no one's left behind, and lastly, and that is the universal health coverage is all about, if you look at the middle of the slide, it says making quality oral health care affordable, accessible, and available for all. And that's what universal health coverage is all about. So the universal health coverage was approved by the UN for every country in the world to be able to follow, which is affordable, accessible, and available healthcare for all. And there were only 2 diseases that were mentioned in this document. One was eye disorders, and the other thing was oral health, as an example of how we need to move forward. So there again, we are at the forefront right now. We're at the precipice of people are listening to us. People want to do this, but we need to be, we, meaning our healthcare professional, we need to be the strong advocates to do that. Next slide, please. Another interesting article that just came out in the Bulletin of World Health Organization was written by Marco Vujicic from ADA, Stefan Listel from Holland, and Carlos Quinones from Toronto. And they actually published a short little article here where they said, okay, what happens if we don't do this? What happens if we don't invest money into our health? Well, what they found was we have lower overall well-being than attainable with available resources. Next slide, please. And interesting, they said, if we don't invest money into our health, we're going to have reduced quality of life, reduced educational attainment, lower chances in the labor market, compromised social participation, exacerbation of other non-common diseases, and waste of resources due to avoidable treatment costs. Their conclusion was that the cost of not having our health is much greater to society than having good oral health. So here again, there are enough information out there. There is enough information out there for us to take the policymaker and say, listen, if you don't invest in our health, it's going to cost you much more somewhere else, but it's going to cost you much more. And that's why we need to sit at the table. Next slide, please. So who are the stakeholders? Well, who are the people that need to get involved in this call to action? Let's call it that. Healthcare students, educators, respective association, accrediting bodies, healthcare professionals organization, not only students and educator, research organizations, industry, commerce, partnership, health economists, policymakers, funders. But here, the last two ones are the ones we never really talk about in oral health. Patients advocacy group and people in civil societies. Next slide, please. So when I was editor of JADA, I had an opportunity to publish, next slide please, to publish articles, obviously editorials. And these are two editorials I published not long ago. The one to the right says, promoting the importance of our health, where are our patient voices? Meaning what I said was, there is really no one out there to speak up for oral health. I don't know if you watched, but it was around 2 weeks ago, Ronaldo, the soccer player, the football player from Portugal, he was at a press conference and there were 2 bottles of Coca-Cola standing there for him to drink. And he took the Coca-Cola bottle, put them aside and took up a bottle of water and said, aqua. It actually caused the share of Coca-Cola to drop almost $4 billion the next day. We need someone out there to speak up for our health, why sugar is not good, why it's better to drink water than Coca-Cola, but we need someone out there to speak up for our health because otherwise it's not going to happen. That's the one part. The second one is the one to the right. When we talk about the relevance of our health, we always tell the patients the importance of our health. Now the patients are the ones that need to realize that they are the one to determine the relevance of our health. They are the one who's going to tell us what is important to them. Next slide, please. And we see that now because today, and this was published on March 18 here in British Medical Journal, and these are 2 individuals who wrote this article here, are 2 individuals at the absolute the forefront of evidence-based medicine. They are the gurus when it comes to evidence-based medicine, and they looked at how they have been teaching evidence-based medicine for many, many years, and they did a retrospective evaluation of what they did. And what they found was that the most important thing was for trainees to understand that evidence is never sufficient to guide clinical practice, but what we need is patient values and preferences, and they are absolutely crucial. Next slide, please. And the importance of this, next slide, please. And the importance of this is because we need to do shared decision-making in order to do evidence-based practice. We need to be able to discuss what the evidence are with the patients, which means we need to educate our patients. So the patient has never really been involved in our healthcare proactively. And I think one of the things that we have failed as a profession is that we haven't told our patients that they don't need to get caries, they don't need to get periodontal disease, but they expect it. Next slide, please. So let me summarize here in next 4 or 5 slides. Are we willing to ask the hard questions? Are we teaching our students to employ scientific approach to our health? Are we educating our students on how to become advocates for our health? Are we educating our patients on how to become advocates for our health? Who is the educator? Can we do it? For instance, if I went into certain neighborhoods where I live, They will never listen to me being an older white male. They want someone that comes from their neighborhood to be the educator. Otherwise, they would never listen to me. What should our health workforce look like? Do we only need dentists and dental hygienists and dental assistant, or should it be something else? Do we have the evidence for evidence-informed health policy? And I think it's very clearly that we don't. And how do we justify the need to integrate oral health with overall health? And the justification is very clear. You cannot have good overall health without good oral health. Next slide, please. So bottom line here is, what should we look for in our healthcare professional? All right, stop there. Up, okay, thank you. No, that's okay. Go one more. There we go. Apply scientific method to provision of our healthcare, interpret and understand the scientific literature, use a critical thinking approach, and to participate in an integrative person care model. So what do I mean by integrative person care model? Next slide. There are 4 things. Understand the significance of the association between our disorders and medical conditions. Next. Screen for medical conditions. We can screen for medical condition in dental office. You can screen for diabetes and cardiovascular disease and hypertension and many different things. You may be not going to make a diagnosis, but you can screen for it. Next slide, please. Maybe we can participate in interprofessional care, meaning can we give immunizations? Absolutely. We give injections half the way up the brain when we do the greater palate and foramen block. Why shouldn't we be able to give an immunization in a deltoid? Next slide, please. And maybe we should use the oral healthcare setting as a portal into the healthcare system, meaning we can screen patients for oral diseases and then have them being referred to physicians in order for us to treat these patients together. Next slide, please. We need to advocate for our health within all policies. Next. We need to keep going. Practice evidence-based oral healthcare, understand the social context, and this is very important, the last point here. See people and systems through the lens of equity, diversity, and inclusion. So what do I mean by that? Keep going. We need to understand the contribution of behavioral and physiological risk factors in social economic determinant health delivery system. We need to understand where the person is coming from. We need to understand how their circumstances, social, physiological, behavior, risk factors affect their oral health. Unless we take those into consideration, we are never going to achieve optimal oral health for all. Next slide, please. So what I think we have here is poor oral health is a syndemic. A syndemic is actually 2 epidemics that happen at the same time. Syn may combine. It's an epidemic of oral disorders combined with an epidemic of non-communicable and other systemic illnesses. Oral disorders by itself cannot be solved unless we solve it together. And these epidemics exist and interact both on a biological level, there are causative relationships back and forth, as well on a social level. Next slide, please. So I spoke about common risk factors. Next slide. If I look, for instance, at bad diet, next slide. Diabetes, cancer, heart disease, as well as oral diseases. Next slide. Stress, next slide. Stress affect heart disease, as well as periodontal disease. Next slide, please. Smoking, next slide. Cancer, heart disease, respiratory disease, periodontal disease, cancer, next slide. Even exercise, alcohol, next slide. And even exercise, next slide. These are common risk factors, meaning we don't need to prove that periodontal disease causes cardiovascular disease. We know that there are same risk factors for both of them. So why can't we integrate the care for patients with oral health problems together with people with systemic problems? Next slide, please. On June 17th, so around 10 days ago, there was a big article, actually an editorial in the journal Nature. Next slide, please. And what it said was the COVID epidemic has taught us something very important, that we need to successfully collaborate and trust and establish long-standing relationship. And the future doesn't lie in individuals, it lies in the crowds, it lies in groups of individuals that work together. We used to say that we stand on the shoulders of giants. Now they say the future lies in standing on the shoulders of crowds. So collaboration, facilitation, that's what we need. Next slide, please. So the moment to act is now. Next slide. The clock is ticking. We need to facilitate, to collaborate, to partnership. Next slide, please. And we need to generate evidence. We need to advocate, and we need to educate. Next slide, please. So with that, hopefully I have given you a little bit of a taste of what this new Center for Integrative Oral Health is all about. July 1st, I'm taking on the position, being executive director actually of this new center set up at the University of Pennsylvania. And one of our main tasks is to be able to, in the future, become a center for evidence-informed health policies. In order to do that, we need to go backwards, we need to find the data, we need to be able to talk about the same data, we need to start to educate patients, we need to educate policymakers, we need to educate ourselves in order to understand the science and move forward. So there's tremendous potential to do something good here. And hopefully, if I can call on all of you in the future, if we can do this together, we should be able to do it. On our own, we cannot do it. We have to stand on the shoulders of crowds. So with that, thank you for your attention. I know it's late at night, and I hope all of you stayed awake here. And if there are any questions, I may not have answers, but I might have even more questions for you. So thank you again for your attention.
Okay, we're gonna go to one very short video, Michael, and I'll come back with you to take care of all the comments and questions. Thanks. Don't go away.
La línea Guard también ofrece soluciones para quien presenta problemas en las encías. El ya conocido enjuague bucal Colgate PerioGuard con clorhexidina al 0.12% ayuda a controlar el nivel de bacterias presentes en boca. Debido a su amplio espectro bactericida, reduce hasta un 99% las bacterias bucales, reduce en un 48% el sangrado gingival y hasta en un 54% la placa bacteriana. No contiene alcohol, tiene un sabor agradable a menta, fácil de utilizar y con altísimos estándares de calidad y validación científica que lo distinguen de otras clorhexidinas. Al enjuague Colgate PerioGuard se le unen dos nuevos productos que complementan y ayudan al tratamiento de las personas con problemas de encías. La nueva crema dental especializada, Colgate PerioGuard, con una fórmula a base de zinc que garantiza una acción antibacteriana prolongada que ayuda a prevenir la inflamación de las encías, la formación de placa y sarro dental. Ayuda a prevenir el sangrado gingival hasta en un 66.7%. Puede ser utilizada de forma diaria y prolongada, ya que su principal ingrediente activo se encuentra de forma natural en el cuerpo humano. Y por último, el nuevo cepillo dental especializado Colgate PerioGuard, de cabeza compacta, mango ergonómico antideslizante y con exclusivas cerdas cónicas Perisoft ultra suaves con puntas de filamentos microfinos, garantizan la eliminación profunda y eficiente de la placa bacteriana sin dañar las encías. Gracias a su cabeza con anatomía diamantada y componente de caucho, evita traumatismos durante el cepillado. Colgate, siempre a la vanguardia del cuidado bucal, presentó Colgate Guard, la ciencia detrás de tu sonrisa.
Well, that was amazing, Michael. I don't even know where to start.
I tell you what, Jaime.
Yeah.
I tell you what, Jaime. I tell you what. Invite me back 5 years from now, and let's see if we can answer some of these questions. How about that?
No, well, no. It's not asking, but I think you're this is a war, and you open just like 100 different. I tell you, when I was listening, I said, I'm gonna try to come up with the first reason for such a failure in oral healthcare, and I think that the dentists have all along all these years, 200 years of dentistry, 230, 40 years of dentistry. I think we have blamed the patient exactly the same way the MDs blame their patients because, oh, you had a stroke because you smoke and you're overweight and you're you eat too much tacos, and so but now I think you're opening a huge window, and I my first feeling was, is it time to blame the profession for the
I
lack
think we
of
have no,
results?
I think we have no one else to blame, Jaime. You know, you don't doing a below knee amputation on a diabetic patient doesn't treat the diabetes, right? So if you suddenly got caries in your teeth because you have eating too much sugar or you didn't do toothbrushing or flossing or whatever, treating that, taking that tooth out doesn't cure the problem. It just takes care of one side effect of the problem, doesn't cure the problem at all. So what we've done is we're trying to drill ourselves out of a problem that should have been taken care of by prevention and education, in my opinion at least. All right. So I think we should blame ourselves for it. The problem is that, you know, if the burden is very great and people are coming in pain and they need to have something done immediately and so on and so forth, well, you don't have time for much else to do. But what we've done, and I think one of the slides here where I show that horizontal workforce thing, that we are only talking about dentists, we need to involve a lot of other healthcare professionals in this whole thing. We can't do it on our own. There's not enough of us. There need to be people in the communities that are ambassadors for our health, that we teach them, we educate them, and that's where it starts. If I would select one single group right now that I would focus on, would be pregnant mothers.
Yeah,
If you can get pregnant mothers to understand the importance of our health, that would then translate into their children and maybe the next generation.
yes, but on behalf of the profession, we came on board when the problems were already there.
Right?
I don't know. I don't go that far back in the history of dentistry, but I think the first mistake was the to charge per service, and not as you're trying to implement now, for cure. So patients were never cured. They were just, you made the necessary changes in their teeth, in their gums, in order for them to keep talking, chewing, smiling,
So
but
let
no,
me so let me
nothing to
give
cure.
you so let me give you a controversial one in that case. Should we get paid for improving people's oral health rather than getting paid for doing a class two amalgam?
Um, well, no, that's what I mean. I mean, it comes from the training, right? You have to do
Yeah,
100 amalgams. You have to do 200 resins. You have to do 10
right.
onlays. So the first view of the patient was not integrative. It was completely diverse. It was
Yeah,
just look for the things you needed to know in order to do them in the
that's right.
way that you were trained. You were not taught. You were trained. Like you you drop the ball, and the dog goes and picks it up and brings it back, and he gets a candy. That's training. So a lot of dentistry relies on training, not on
That's right.
educating. Is that
I agree with
first?
you.
Should we blame
100%.
our teachers now?
I think you and I have known each other too long. We speak the same language.
Yeah. No, I want to provoke the discussion. But now, number two, uh, the myth is that good dentistry is very expensive. But does good dentistry cures?
Good dentistry is very expensive, but as I showed you here, um, no dentistry is even more expensive.
Well, that can be, and then I would tell you, well, how much of dentistry is virgin dentistry today, and how much is repetition dentistry until you get good quality. But still, that doesn't mean you cure the patient. You haven't changed
Yeah,
his sugar intake. You haven't taken care of his stress, no. And
But
I can tell
Jaime,
you
one
that
of the
here.
challenges, yeah, so one of the challenges we had when we created the Vision 2030 is we can come up with an optimal way of treating and educating patients. And maybe they work in Manhattan, in New York City, but do they work in Ethiopia, where you have one dentist per million patients? Can we provide the same type of oral health care? Or a dentist to make $600 a month? Will they have time to do prevention and education and advocacy and everything, all the good stuff that I suggested here? You know, every place and every community, um, we have to take that into consideration. So we can come up with great ways to do things, but then we have to apply it to the places where we want to implement them. And that's a huge challenge. I didn't talk about that, but that's a huge challenge that we have right now. So I don't think they do a lot of implant dentistry in Ethiopia. Maybe they do, or in Tanzania or Mozambique. And maybe they do a lot of implant dentistry, but I doubt it very much.
No, well, I understand, but maybe I didn't explain myself correctly. I think that no matter how good dentistry you do, you still don't cure the patient. The
Correct.
patient is in a
No.
stage.
Wait. Let's go back to my first slide. When you say doing dentistry, do you and I talk about the same thing? Because to me, doing dentistry is also prevention.
No, I know, but that's what I mean. Dentistry is not oral health. Dentistry is
Ah,
one thing, right? And care for health now is a different thing. I mean, we were blind for
Jaime,
so many years.
Jaime, I think you got it.
No, I mean, no. But you know,
I agree.
who feels
I
like a good
agree. That's
dentist?
what I'm saying.
He
That's
who
what I'm saying.
can.
We need to get paid. We need to get paid for our health, not for doing what you claim,
Yeah.
what you say. And I agree, is dentistry. We need to get paid for improving a patient's oral health.
And you think it's going to
But then
happen
we
in
have to
our
start.
time?
Then we have to start to define our health. We have to measure it, and we have to be able to measure improvements.
Is it that some people are watching us from Europe? Maybe they're going to watch us tomorrow because this is being taped in these social platforms. But do you think they would accept in certain countries where the dentist is the center of the world? Do you think they will accept a nutritionist, for example, as part of your practicing dentistry or your
No, but
infirmary?
that's. But I go back to what I said before. You know, in the Vision 2030, and this is the way I describe it, we gave a map. Each country will create their own roadmap, because I cannot tell you how they're going to practice in Germany or Japan or Hungary or Italy or Morocco or any place else. I'm not going to tell them how to do it. I can tell them what the opportunities and challenges are, and they have to apply it to the need of their own circumstances. And that includes political circumstances, by the way, as well. Reimbursement, politics, everything there. So we can come up with these best buys, as I mentioned, but unless we can apply them some other place, they're not going to work. We have to be very open about it. We cannot be dogmatic about it. We have to be open enough about it that we know that we have to tweak and change and see how things work differently in different places.
Now, Michael, you know I'm an illiterate dentist as when it comes to science. I don't understand science. I rely on friends, good friends like you that can explain it to me. So, do you think, we are watched by teachers in different kind of dental schools, oral health schools? Uh, is it enough? Is it lack of research, or is it that a very important percentage of dentists are illiterate like me? I want to practice evidence-based dentistry, but I cannot reach what's being published. It's a, to me, it's like it's a very small audience the one that can really understand all this research that comes out like it's pouring, but it doesn't touch the end user, which is, well, the dentist taking care of his patient. How do we solve this?
All right, so there is one solution. I'm not saying it's the only one, but if you look at this as a pyramid, where you have the practicing dentist at the bottom, right? And then you have researchers, and then you have evidence-based specialists, etc., etc. And on the top, you have people who can take all that information and make it into clinical guidelines, all right? Those clinical guidelines might be good enough for you. Now, the problem we have is that we can come up with the best clinical guidelines, but I have dentists going to say, wait a second, what I'm doing in my hands, in my practice works well. I don't need clinical guidelines, all right? So you're still going to have this whole thing that, yeah, you guys are academicians, you're scientists, don't tell me what to do, I know what to do, okay? But I don't expect that every dentist should be able to read and understand a randomized controlled trial and tell me if the research design was correct and if the statistical model that was used was correct or if they used to say, etc. No, I don't want to do that. That's never going to happen. But what I would like people to know is those things exist, and those things are the basis for these clinical guidelines that very smart people are putting together. Now, then the question is, not every clinical guideline is going to be as good as everyone else. Garbage in, garbage out, unfortunately.
Well,
Right?
who can tell you what to accept and what to reject?
Ah, um, do you have another hour?
No, but I mean, is it only my view of, or you agree that there are a lot of dentists out there that don't really understand? Some understand, yes. Some think they understand, and some are open enough to say they don't understand. But even though it's like, oh, come on. Now, I can see that a specialist will focus on his area and who would understand research of his field of specialty. But the base of dentistry is general dentistry. Are we? How would you do it from scratch? Let's say there are no dentists in the world. They were all killed. We were all killed in a in an imaginary zombies world. How would you build dentistry from zero up?
I would start with who I accept into dental school. Sorry, let's go backwards. I would start with who the educators are, and then who I accept into dental school. And I don't think I would accept the same type of students today that I would if I could start it absolutely from scratch. What I mean by that is, and there's no value judgment here, so don't get me wrong.
Yeah,
But I think the vast majority of people go into dentistry is to have a good profession and make a good living. Now, there's nothing wrong with that. There's nothing wrong with doing that, obviously. But we should also have a cadre of dentists that go in there in order for them to maybe have more understanding of the inequities and diversity and being. I mean, I can only take United States as an example. There are very, very few minority dentists out there. There are very few people that go into areas where they are truly needed and they're different. Let's say Native Americans as an example. There are hardly any Native American dentists. So, and you're not going to find a lot of other dentists willing to go into and treat those patients in the areas where they live. So we have to set it up very differently in that sense, I think. And then we go back to what type of dentistry they're supposed to perform. And then again, we talk about education, talk about, I mean, Jaime, this is something that I think we should put together a panel of people. You only have my opinion here right now. You put up a panel of people, and you're going to get a lot of different ideas, and they're all good. I have no problem with it. They're all going to be good. They're all going to be valid. The question is, do someone have the guts to try them out? Because the problem with all this is we're not going to get an answer tomorrow. It's going to take 5, 10, 15 years until we know it's going to work.
Well, let me just ask you something. Isn't it not in an ideal world, but in today's world, with the capabilities of digitalization of everything, you can digitalize the smile and recreate somebody's smile in somebody else's mouth.
I'm actually 127 years old.
You look good for that.
This is just my digital image.
Yeah. It's an echo of things past.
Yeah.
No, no, but can't we, if we move to the digital control? My question comes from this. The ADA tells you, or where something along the line, the ADA told the insurance how much a crown should last. And that's how often they pay to replace the same crown. But that's, like you say, it's an average. It has to do with so many variants that, some crowns may last 4 times as long, and some crowns, when the diagnosis wasn't correct or the technique wasn't correct, the crown can last no more than a year or 2. But now that we have digital systems that you can put in your office, or they can put in schools, and you can see really how long things last. And could that be one of the windows towards a cure, to getting paid by curing, not by doing, how many resins can you do in an hour, or how many crowns you can produce? Or the worst thing is in my mind is, we come from the age where some, gold was between your teeth and not in your heart, like the song says. You're young when gold is in your heart and not between your teeth. Well, gold is no longer between your teeth because people want white. But we were sellers, merchants. Oh, the gold crown is more expensive. The non-gold is less expensive. The silver, it's like we were in the market selling tomatoes and pineapples. I hate it. I simply hate it. Let's go to our last video and then we come back for the final. There are a lot of comments. Actually, there are no questions. They're just comments. I'll read them to you. Okay, don't go away, we'll be right back.
OrthoGuard es una línea completa especializada para quienes usan aparatos de ortodoncia. Cuenta con 3 productos de uso diario que ayudan a prevenir las lesiones de mancha blanca en los dientes. El enjuague bucal especializado Colgate OrthoGuard, con una fórmula revolucionaria en el segmento de los enjuagues bucales, le proporciona a los consumidores una efectividad terapéutica en el tratamiento ortodóntico y en pacientes de alto riesgo de caries. Llegamos a los espacios irregulares generados por la adhesión de la resina y el bracket, previniendo la desmineralización del esmalte hasta un 58%. Libre de alcohol, sabor agradable y de uso diario en personas de 6 años en adelante. El nuevo gel dental especializado Colgate OrthoGuard, con 5000 partes por millón de fluoruro de sodio, ideal para personas en tratamiento de ortodoncia y o con alto riesgo de caries. Revierte 3 veces más las lesiones de caries inicial y proporciona hasta 40% mayor reducción de caries contra una crema dental regular con fluoruro. Es seguro y se recomienda usarlo diariamente, una vez al día durante el tratamiento ortodóntico, indicado para personas de 6 años en adelante. Durante el tratamiento de ortodoncia, los cuidados de salud bucal exigen mayor atención. Los brackets y alambres ortodónticos pueden impedir una buena higiene bucal. Por eso Colgate ha creado el cepillo dental especializado Colgate OrthoGuard, con cerdas multinivel, indicado para quienes usan aparatos ortodónticos. Gracias a su forma en U, cubre toda la superficie del bracket, mejorando el efecto de limpieza en la encía, dientes, alambres y brackets. Las cerdas se externas en forma de espiral eliminan la placa dental en la línea de la encía, proporcionando así una mejor sensación de limpieza en los tejidos bucales. Y a su vez, las cerdas internas auxilian en la limpieza alrededor de los brackets y alambres ortodónticos. Sus puntas de 0.01 milímetros pueden limpiar pequeños espacios, proporcionando una mejor limpieza de la superficie de los brackets y alambre. Colgate, siempre a la vanguardia del cuidado bucal, presentó Colgate Guard, la ciencia detrás de tu sonrisa.
Esto es lo que vivimos todos los días. Los odontólogos debemos ser vacunados a la brevedad posible, pues nuestra profesión implica un contacto directo con una fuente de transmisión importante, la boca. A pesar de todas las barreras de protección sanitarias que llevamos, no podemos dejar
Los odontólogos seguimos en riesgo, porque no hemos sido considerados para recibir la vacuna como miembros del equipo de salud.
Vacúname.
You see, Michael, it doesn't matter how much pressure we made as dentistry, we were never vaccinated as dentists because the same stupid doctor who said that the children with cancer don't exist and it's just to make pressure towards the government is the same one, this exactly same one that said that food, the people from Uber Eats or Didi or these services that brings food to your house are more in risk of getting COVID because they deliver 75 meals per day and a dentist see only 6 patients per day. He never talked about the 25, the 10 inches distance between an unmasked mouth of your patient and yourself. But it's incredible. No, you see, there are a lot of congratulations for you for the lecture, an excellent point of view of prevention and promotion of oral health. We hope these talks would be listened by the decision makers in the health policies of our country. Simply the best. Excellent, very good talk and comments. I hope that what the doctor proposed, your proposal, will be really a reality for 2030. And as you said, we can only do it together. Regards from friends. We can take all this information and rewrite the story through the Mexican Dental Association and the association members. And if we get integrated, would you give us your opinion on where to start to bring this into reality in Mexico? What will be your start point?
My starting point would be to learn Spanish. Otherwise, there's no way I can do it. No, the starting
No.
point.
What would be your suggestion so we Mexicans can? How we Mexicans would start to?
I think a very important. Yeah, I think a very important part would be actually to invite policymakers to sit around the table with you, to educate the policymakers.
Well, imagine who the policymakers are.
Well, but they are the ones who's going to determine what's going to happen.
We are part of the menu. We're not part of the
Okay.
we're not invited at the table. We're part of the menu.
Yeah, but Jaime,
And
if you want to have change, if you want to accomplish change, it has to go through the policymakers. They're the one, with the big. They're the one with the big monies. They're the one with the big umbrella. If you want to be under their umbrella, you have to sit with them.
No, I want to tell you that as far as of the dentistry department of the Ministry of Health, both in Mexico City and the rest of the country, is great. The problem is always the same. We are dentists. We don't get enough budget. We cannot do a lot of intervention. It's a pity. But actually, I want to congratulate all the people from the Ministry of Health that belong to the oral health or dentistry division, because they're really pushing, and it's been a long fight for years to have a better. So dentists in the public systems are treated better, starting by then. This happens everywhere. Um, well, this is a long question. What public policy proposes the FDI? Well, you can go into the webpage, and there are all kinds of public health policies that are now in order. You can read them and try to understand them. Educate the educator. Somebody suggests this as the first step. Promotion and education in oral health to all patients, especially the children, pregnant women, and chronic patients, and have a follow-up of these patients to make them aware of how important is their oral health. I don't understand this question. What's the work for the cost of dental care? I really don't understand the. Congratulations, very important subjects. Oral health professionals should be included when taking these decisions. Michael, I know it's late. You have a very long flight tomorrow. I just want to thank you, and I want to know if you want to do any last comments before we let you go.
No, I mean, thank you for inviting me, and thank you for all of you for listening. And I think if we can start a conversation, we could come up with solutions. We could come up with strategies. My intention tonight was and I think I succeeded, is to get people to start to think about this, to start a conversation. And I cannot give you the answers. I mean, you have to come up with an answer. I'd be happy to participate in a conversation, but that conversation needs to start, Jaime, how you will move forward. As you saw, I mean, I had 50 slides here with 100 questions. Pick the one that you believe I can come back again, and we will help out as much as we can. And with this new center now at the University of Pennsylvania, we are going to have a global reach. And we will come back to you guys and figure out how we can help each other. With that, I mean, we can help you, but you can also help us to get better by showing us what works and what doesn't work, right? It's a two-way. This is going to be a two-way street.
Well, I just will take your word, and we'll do it. You know, we've been working towards creating focus groups and listen to the patients. Not in a dental chair, but in a non-stressful ambience, and see what kind of information we can learn. And we're with your guidance, we're doing this in the Mexican Dental the foundation of the Mexican Dental Association, and we're probably going to have results very soon. Thank you very much, Michael. Have a safe trip.
Thank you. Thank you.
Forth and back.
Thank you.
And we'll talk to you later. And for the rest, thank you again for being with us. We're going to have a very interesting lecture in 2 weeks' time, and it's going to be in Spanish, and we're going to be back in our regular schedule, 9:00 Mexico City time. For now, I just want to thank Colgate-Palmolive Mexico for all their support, as well as Ideas Dentales with O Radical for their support in the production of this program. And thank you all the people in the production, Grupo Produce in León, Guanajuato, all the people from ID Academia in Coyoacán in Mexico City, and our excellent translator tonight, Lilia Castañeda. Thank you very much. So we'll see you in 2 weeks' time. Hasta la vista, baby.
Si te lavas bien las manos, lograrás prevenir con jabón y un buen tallado tu salud hoy queda en ti. Mas no olvides que tu boca es otra fuente de infección. Cepillarte bien los dientes te